Hi, my name is Nichole Hoang, and this is my favorite paper presentation. My paper was about implementing health promotion activities using community-engaged approaches in Asian American faith-based organizations in New York and New Jersey. And this paper was published in 2017. The objective of the study is to examine the effect of cultural adaptation and implementation process of REACH-BAR program across diverse faith-based organizations and religious denominations serving Asian American subgroups. REACH-BAR stands for Racial and Ethnic Approaches to Community Health for Asian Americans. Nearly one-third adults in the US have hypertension, and cardiovascular disease is the leading cause of death. Asian Americans make up 5.6% of the US population, corresponding to around 14 million people, and is the fastest growing racial and ethnic minority group and represents a complex and diverse mix of people. There are rates of poor control, such as cardiovascular disease prevention and hypertension management, that are disproportionately high in some racial ethnic communities, including Asian Americans. It was found that there was a lack of culturally adapted programs and educational materials to promote hypertension management or healthful behavioral changes for Asian Americans, and existing programs are limited in sustainability and scalability. The study used REACH-FAR as the community-engaged approach to promote health within these communities. And as mentioned, REACH-FAR is the racial and ethnic approaches to community health for Asian Americans. It's a project that implements a multi-level and evidence-based health promotion and hypertension control program in faith-based organizations serving Asian American communities. This includes Asian American communities of different subgroups across multiple denominations. Subjects in this study are from 12 faith-based organizations, including Christian, Muslim, and Sikh. The Asian American subgroups are Bangladeshi, Filipino, Korean, and Asian Indian groups from New York City and New Jersey. The program was culturally adapted across congregation and faith settings using the ecological validity model. And baseline measures were also used, such as congregate surveys that assess social norms and diet, hypertension participant program surveys, faith-based organization environmental strategy checklists, and community-partnered in-depth interviews assessing project feasibility. In addition, faith-based organization sites use a program from the Department of Health and Mental Hygiene called Keep on Track in order to facilitate community clinical linkages and to increase individual level awareness of the importance of blood pressure control. It is a blood pressure and monitoring program for congregate members between the ages of 18 and 85 years and are not pregnant at the time of recruitment. Measures in the study were culturally adapted as needed, such as incorporating cultural foods and language translations. Both quantitative and qualitative analyses were done. Significant differences across Asian subgroups were determined using chi-square analyses for categorical variables and one-way ANOVA for continuous variables. All statistical analyses were made using SPSS software. A two-sided p-value less than 0.05 was considered statistically significant, and meeting minutes and in-depth interview transcripts were independently reviewed and coded using Atlas TI-6. This table displays findings from the REACH-BAR faith-based organization congregate surveys. The findings include social norms, attitudes, and access to healthy foods and beverages in New York City and New Jersey. The findings in the red box show the attitudes of each group based on their perception of their overall diet. The Korean group had a highest percentage, with 50% in the excellent and very good category. The Bangladeshi group had the highest percentage with 64% in the good category, and Asian Indians had the highest percentage with 25% in reporting that their diet was very poor. Koreans had the highest percentage with 55%, reporting that it was difficult to choose healthy food options at community meals at their place of worship. This is a continuation of the congregate surveys. Findings show that Filipinos and Asian Indians had relatively higher percentages in reporting that fruit, fresh vegetables, whole grains, and free water were usually or always available in their faith-based organization, and Koreans had the lowest percentage in the study. This table shows findings from the Keep on Track program, participants' baseline characteristics. Within the highlighted findings, 33% Bangladeshi, 17% Filipino, 31% Korean, and 29% Asian Indian subjects were reported to be hypertensive. Bangladeshis had the highest percentage, with 58% to be told that they have high blood pressure, and each subgroup also showed high percentages for prescribed medication to control blood pressure of those who were told that they had high blood pressure, as well as currently taking medication for high blood pressure of those prescribed medication. Overall, the 14% of respondents reported their diet as fair or poor. Koreans were less likely than other groups to report that their FBO settings usually or always provided healthy options, and were most likely to answer that it was difficult to choose healthy options at communal meals, and that healthy options were not served at the communal meals. All differences across subgroups were statistically significant. The mean systolic blood pressure of the subgroups was 127.5, and the mean diastolic blood pressure was 80. In terms of clinical variables, Bangladeshis were most likely to present as hypertensive. Overall, 42% of subjects had been told by a health professional that they have high blood pressure, and this was highest among Bangladeshis with 58%. Of those told that they had high blood pressure, 89% had been prescribed medication to control blood pressure. This was lowest among Asian Indians and Filipinos, with 82% and 84% respectively. Findings from the study show encouraging evidence for the role of faith-based organizations for health promotion and suggest that adopting interventions such as cultural, linguistic, and organizational or setting level characteristics can result in successful implementation and uptake of health promotion strategies. Both self-reported and measured blood pressure and BMI rates for participants were aligned with or exceeded those reported in other published studies. Therefore, faith-based settings are an appropriate venue for reaching Asian individuals at high risk for cardiovascular disease. There is a need to implement strategies that are low cost, easy to use, culturally relevant, and can successfully reach these underserved populations. In addition, these findings may not be generalizable across all Asian American serving FBOs, especially since there was a relatively small sample size, considering it only included certain ethnic groups and religious affiliations. Therefore, further research is warranted to evaluate the efficacy of the multi-level strategies implemented in faith-based organizations to improve blood pressure control and nutritional practices of congregants. These findings can guide future implementation efforts in Asian American FBOs, given that there is limited research and FBOs were examined to be an appropriate place for intervention with Asian American communities. And that is the end of my presentation. Thank you.